Hi everyone, I'm Jean Marion Apiny, a Senior Midwife at Nama Wellness Community Center. I'm going to talk about the role of health workers in the prevention and management of pre-eclampsia and eclampsia. Pre-eclampsia is a mild system disorder characterized by a rise in blood pressure, proteinuria, starting usually at 20 weeks of gestation. However, some women may be non-proteinuric and yet they're actually having the pre-eclampsia. As health workers, we play a very pivotal role in the prevention and management of pre-eclampsia and eclampsia, right from the community level to the health facility, point of contact to the client, to the delivery period, and then the postpartum period. And what do we do here? When we meet these clients for the first time, we have a very great role to play, which is going to determine the outcomes of our mothers and the outcomes of their newborns. And here what we usually do, or what we have to do, is at a point of contact during the first antenatal care or during the prenatal care, we have to do a thorough risk assessment. During risk assessment, we are going to identify all the mothers who are at risk of developing pre-eclampsia or eclampsia. We do a thorough history taking, paying attention to detail, delving so much into the family history of this mother, history of pre-eclampsia and eclampsia on maybe the previous pregnancy, a family history of hypertension, and then also if this mother has chronic hypertension. There are also other chronic illnesses like diabetes mellitus, which could also predispose this mother to this other condition, which is pre-eclampsia or eclampsia. And then also other risks like multiple pregnancies. So during this process of thorough history taking, we're able to identify these mothers who are at risk and help them as early as possible into the best that we can do. And then we also have to pay attention to this mother's information. If it is not the first point of contact, if it is maybe a recurring visit, we should be able to look at this mother's antenatal card, look at all her documents clearly, keenly, and be able to realize or look at the blood pressure readings. We usually think that as long as the systolic is between 100 to 140 millimeters of mercury for a pregnant woman and a diastolic of 50 to 90 millimeters of mercury, we take this mother to be normal. That not all of them are actually well. A mother can come in with a blood pressure that is in those very ranges, but with actually signs of pre-eclampsia. We need to look at these mothers' readings on the antenatal card. Are you able to realize a rise in the systolic or diastolic blood pressure? We have to note that if the systolic blood pressure is having a rise of 20 millimeters of mercury and over, regardless of the range, and a rise by 15 millimeters of mercury for the diastolic blood pressure, this mother needs keen and continuous follow-up. She may be at a high risk of developing pre-eclampsia and eclampsia. So just not have to look at the normal ranges and assume this mother is okay. She may actually not be okay. Still during the risk assessment, we involve the family, the next of kin of these women, so that they're able to know what we are talking about and be able to help when these women are out of the facility. After doing the risk assessment, we mitigate the risks. And here we are doing lots of all that we can do to make sure we prevent this condition from progressing, or to prevent this mother from progressing into a pre-eclamptic state or an eclamptic state. And we are looking at both the prophylaxis way and also the health education bit of it. And here we health educate them. If she is at risk of developing pre-eclampsia, we health educate them on the signs and symptoms. How does a mother with pre-eclampsia present? If you get this danger sign, if you're having a blurry vision, if you're having epigastric pain, if you're having continuous frontal and hospital headache, what do you do? Go to the health facility. We need to build their capacity to also be advocates to the communities where they come from, so they can be able to health educate the other women who are at home, as long as they're of reproductive age. Still under mitigation, we also do the prophylaxis for all the high-risk women. If a woman has had a previous history of pre-eclampsia, a previous history of eclampsia, it is advisable that we initiate these mothers on a low dose aspirin of 75 to 150 milligrams. And this should be started as early as before 16 weeks of gestation. Why are we doing this? We are trying to prevent the risk, or to prevent this mother from going into that other state which we do not want to know, or we wouldn't want this woman to go into. So this low dose aspirin will help to prevent the recurrence of the pre-eclampsia and eclampsia. For the women who are having a low calcium intake in their diet, we also start them, even though she's taking the calcium, but the supplements of calcium are also very important in this mother's body to prevent her from having a recurrence of the pre-eclampsia and eclampsia. We also have to educate them on the foods they need to take, foods rich in calcium, and then all the nutrients they need to get, and what they need to avoid if she's having a risk of pre-eclampsia and eclampsia. And then for those that are having community health workers in the facilities they work in, also bring them on board, build their capacity, and assign those high-risk women in the villages they come from to always follow up on these women. It's easy to follow up with a health worker. In case of any sudden change in this mother's condition, she's able to communicate, and this mother is able to get assistance without causing all those 3 delays, which will contribute to the mortality and morbidity. And in this way, we'll be contributing to the SDG 3 by helping these mothers have a better life, helping them be happy with their babies after delivery. But if we fail in this area, then it means we are reducing on the good outcomes of the delivery and the postpartum period. And then those that are working in the basic care facilities, after giving the emergency treatment or after giving the first doses, let's encourage these women to go to the basic comprehensive care facilities so that they're able to be reviewed. And there are very many tests that need to be run. We need to do the urinalysis. Some of them need to do the renal function test, liver function test. If we keep them in the basic care facilities, we won't be able to achieve what we want of them. So let's do the early risk identification, early referral, to be able to reduce these delays which cause maternal mortality and morbidity. And usually after referral, we need to follow up on these women and find out how they are doing. If they return back to the community, how do we help them to ensure they do not progress to the state that we wouldn't want them to go to? And then after that, if you're going to clinical management, she's having the eclampsia or she's having the pre-eclampsia, we have to do the clinical management coupled with the mentor, the psychotherapy, considering in the woman's family. They need to know what is happening, and also this mother has to be managed on both the antihypertensive drugs, the anticonvulsants. These all play a great role in saving this woman's life and saving this baby. If we do that wholeheartedly as a team, continue pushing for it, love these women, encourage them, be a good support system to them, then we will achieve a better Uganda and will improve the outcomes of care at all points of contact. Thank you very much. To love and serve.